SARS, severe acute respiratory syndrome. Severe acute respiratory syndrome, SARS, is a viral respiratory illness caused by a coronavirus, called SARS-associated coronavirus, SARS-CoV. SARS was first reported in Asia in February 2003. Over the next few months, the illness spread to more than 24 countries in North America, South America, Europe, and Asia before the SARS global outbreak of 2003 was contained. Cause: SARS coronavirus, SARS-CoV, virus identified in 2003. SARS-CoV is thought to be an animal virus from an as yet uncertain animal reservoir, perhaps bats, that spread to other animals, civet cats, and first infected humans in the Guangdong province of southern China in 2002. Transmission. Transmission of SARS-CoV is primarily from person to person. It appears to have occurred mainly during the second week of illness, which corresponds to the peak of virus excretion in respiratory secretions and stool, and when cases with severe disease start to deteriorate clinically. Most cases of human-to-human transmission occurred in the healthcare setting, in the absence of adequate infection control precautions. Implementation of appropriate infection control practices brought the global outbreak to an end. Throughout the outbreak, the primary mode of transmission appears to be direct mucous membrane, eyes, nose, and mouth, contact with infectious respiratory droplets and/or through exposure to fomites. Cases have occurred primarily in persons with close contact with those very ill with SARS in healthcare and household settings. Transmission to casual and social contacts has occasionally occurred when, as a result of intense exposure to a case of SARS, in workplaces, aeroplanes or taxis, or in high-risk transmission settings, such as healthcare settings and households. Molecular analysis can help to describe transmission trees. A basic reproduction number, I0, of approximately is consistent with a disease spread by direct contact or larger virus-laden droplets that travel only a few meters rather than by lighter airborne particles. By contrast, if a disease is transmitted by aerosols, a single person can infect an entire room by coughing, as can happen with measles and influenza. If so, then simple infection control techniques, such as frequent hand washing, can go a long way towards slowing the spread of the disease. Appropriate respiratory precautions should be sustainable in a fully functioning hospital, and there is a need to establish the new norm in respiratory precautions. The public health sector should focus its efforts on general surveillance of respiratory illnesses, SARS case finding and investigation, isolation of close contacts of SARS cases, and public and professional education. Despite the considerable opportunity, there have been no reports of food or waterborne transmission. However, studies are needed to define the potential role of these routes further. Risk for travelers. Currently, no areas of the world are reporting the transmission of SARS. Since the end of the global epidemic in July 2003, SARS has reappeared 4 times, 3 times from laboratory accidents, Singapore and Chinese Taipei, and once in southern China where the source of infection remains undetermined, although there is circumstantial evidence of animal-to-human transmission. Should SARS re-emerge in epidemic form, WHO will guide the risk of travel to affected areas. Travelers should stay informed about current travel recommendations. However, even during the height of the 2003 epidemic, the overall risk of SARS-CoV transmission to travelers was low. Nature of the disease. Symptoms are influenza-like and include fever, malaise, myalgia, headache, diarrhea, and shivering, rigors. No individual sign or cluster of symptoms has proved to be specific for a diagnosis of SARS. Although fever is the most frequently reported symptom, it is sometimes absent on initial measurement, especially in elderly and immunosuppressed patients. Cough, initially dry, shortness of breath, and diarrhea are present in the first and/or second week of illness. Severe cases often evolve rapidly, progressing to respiratory distress and requiring intensive care. Risk factors for SARS. Risk factors for SARS were described in a number of studies. Healthcare workers, especially those involved in procedures generating aerosols. Other risk factors include household contact with a probable case of SARS, increasing age, male sex and the presence of comorbidities. The care and slaughter of wildlife for human consumption in the wet markets of southern China is associated with serological evidence of infection. There has also been limited transmission related to air travel. The evidence presented at the global meeting on the epidemiology of SARS and published data has confirmed the efficacy of traditional public health measures. It includes early case identification and isolation, vigorous contact tracing, voluntary home quarantine of close contacts for the duration of the incubation period, and public information and education to encourage prompt reporting of symptoms. A global collaborative study on SARS in pregnancy is needed to increase the sample size of case areas. ANCO has estimated that there are 100 pregnant women among the more than 8,000 probable SARS cases reported worldwide. MERS, Middle East Respiratory Syndrome. The Middle East Respiratory Syndrome, MERS, is a viral respiratory disease caused by a novel coronavirus, Middle East Respiratory Syndrome coronavirus, or MERS-CoV, that was first identified in Saudi Arabia in 2012. Typical MERS symptoms include fever, cough and shortness of breath. Pneumonia is common, but not always present. Gastrointestinal symptoms, including diarrhea, have also been reported. Some laboratory-confirmed cases of MERS-CoV infection are reported as asymptomatic, meaning that they do not have any clinical symptoms, yet they are positive for MERS-CoV infection following a laboratory test. Most of these asymptomatic cases have been detected following aggressive contact tracing of a laboratory-confirmed case. Although most human cases of MERS-CoV infections have been attributed to human-to-human infections in healthcare settings, current scientific evidence suggests that dromedary camels are a major reservoir host for MERS-CoV and an animal source of MERS infection in humans. However, the exact role of dromedaries in the transmission of the virus and the exact routes of transmission are unknown. The virus does not seem to pass easily from person to person unless there is close contact, such as occurs when providing unprotected care to a patient. Healthcare-associated outbreaks have occurred in several countries, with the most massive outbreaks seen in Saudi Arabia, the United Arab Emirates, and the Republic of Korea. Symptoms. The clinical spectrum of MERS-CoV infection ranges from no symptoms, asymptomatic, or mild respiratory symptoms to severe acute respiratory disease and death. A typical presentation of MERS-CoV disease is fever, cough and shortness of breath. Pneumonia is a common finding, but not always present. Gastrointestinal symptoms, including diarrhea, have also been reported. Severe illness can cause respiratory failure that requires mechanical ventilation and support in an intensive care unit. The virus appears to cause more severe disease in older people, people with weakened immune systems, and those with chronic diseases such as renal disease, cancer, chronic lung disease, and diabetes. Approximately 35% of patients with MERS have died, but this may be an overestimate of the exact mortality rate, as existing surveillance systems may miss mild cases of MERS, and until more is known about the disease, the case fatality rates are counted only amongst the laboratory-confirmed cases. Source of the virus. MERS-CoV is a zoonotic virus, which means it is a virus that is transmitted between animals and people. Studies have shown that humans are infected through direct or indirect contact with infected dromedary camels. MERS-CoV has been identified in dromedaries in several countries in the Middle East, Africa, and South Asia. The origins of the virus are not fully understood but, according to the analysis of different virus genomes, it is believed that it may have originated in bats and was transmitted to camels sometime in the distant past. Transmission. Non-human to human transmission. The route of transmission from animals to humans is not fully understood, but dromedary camels are the major reservoir host for MERS-CoV and an animal source of infection in humans. Strains of MERS-CoV that are identical to human strains have been isolated from dromedaries in several countries, including Egypt, Oman, Qatar, and Saudi Arabia. Human-to-human transmission. The virus does not pass easily from person to person unless there is close contact, such as providing unprotected care to an infected patient. There have been clusters of cases in healthcare facilities, where human-to-human transmission appears to have occurred, especially when infection prevention and control practices are inadequate or inappropriate. Human-to-human transmission has been limited to date and has been identified among family members, patients, and healthcare workers. While the majority of MERS cases have occurred in healthcare settings, thus far, no sustained human-to-human transmission has been documented anywhere in the world. Since 2012, 27 countries have reported cases of MERS, including Algeria, Austria, Bahrain, China, Egypt, France, Germany, Greece, Islamic Republic of Iran, Italy, Jordan, Kuwait, Lebanon, Malaysia, the Netherlands, Oman, Philippines, Qatar, Republic of Korea, Kingdom of Saudi Arabia, Thailand, Tunisia, Turkey, United Arab Emirates, United Kingdom, United States, and Yemen. Saudi Arabia has reported approximately 80% of human cases. What we know is that people get infected there through unprotected contact with infected dromedary camels or infected people. Cases identified outside the Middle East are usually traveling people who were affected in the Middle East and then moved to areas outside the Middle East. On rare occasions, outbreaks have occurred in areas outside the Middle East. Prevention and treatment. No vaccine or specific treatment is currently available. However, several MERS-CoV particular vaccines and medications are in development. Treatment is supportive and based on the patient's clinical condition. As a general precaution, anyone visiting farms, markets, barns, or other places where dromedary camels and other animals are present should practice general hygiene measures, including regular hand washing before and after touching animals, and should avoid contact with sick animals. The consumption of raw or undercooked animal products, including milk and meat, carries a high risk of infection from a variety of organisms that might cause disease in humans. Animal products that are processed appropriately through cooking or pasteurization are safe for consumption, but should also be handled with care to avoid cross-contamination with uncooked foods. Camel meat and camel milk are nutritious products that can continue to be consumed after pasteurization, cooking, or other heat treatments. Until more is understood about MERS-CoV, people with diabetes, renal failure, chronic lung disease, and immunocompromised persons are considered to be at high risk of severe disease from MERS-CoV infection. These people should avoid contact with camels, drinking raw camel milk or camel urine, or eating meat that has not been properly cooked. Healthcare facilities. Transmission of the virus had occurred in healthcare facilities in several countries, including from patients to healthcare providers and between patients in a healthcare setting before MERS-CoV was diagnosed. It is not always possible to identify patients with MERS-CoV early or without testing because symptoms and other clinical features may be nonspecific. Infection prevention and control measures are critical to prevent the possible spread of MERS-CoV in healthcare facilities. Facilities that provide care for patients suspected or confirmed to be infected with MERS-CoV should take appropriate measures to decrease the risk of transmission of the virus from an infected patient to other patients, healthcare workers, or visitors. Healthcare workers should be educated and trained in infection prevention and control and should refresh these skills regularly. Travel. WHO does not recommend the application of any travel or trade restrictions or entry screening related to MERS-CoV. WHO response. WHO is working with public health specialists, animal health specialists, clinicians, scientists in affected and at-risk countries and internationally to gather and share scientific evidence to better understand the virus and the disease it causes, and to determine outbreak response, priorities, treatment strategies, clinical management approaches. WHO is also working with the Food and Agriculture Organization of the United Nations, FAO, and the World Organization for Animal Health and national governments to develop public health prevention strategies to combat the virus. Together with affected countries and international technical partners and networks, WHO is coordinating the global health response to MERS, including the provision of updated information on the situation, conducting risk assessments and joint investigations with national authorities, convening scientific meetings, and developing guidance and training for health authorities and technical health agencies on interim surveillance recommendations, laboratory testing of cases, infection prevention and control, and clinical management. The Director General convened an emergency committee under the International Health Regulations, 2005, to advise as to whether this event constitutes a public health emergency of international concern, and on the public health measures that should be taken. Countries, whether or not MERS infections have been reported in them, should maintain a high level of vigilance, especially those with large numbers of travelers or migrant workers returning from the Middle East. Surveillance should continue to be enhanced in these countries according to WHO guidelines, along with infection prevention and control procedures in healthcare facilities. WHO continues to request that member states report to WHO all confirmed and probable cases of infection with MERS-CoV together with information about their exposure, testing, and clinical course to inform the most active international preparedness and response. Similarities and differences in disease. As of mid-January of 2020, the time of preparation of this editorial, we are now in the 18th month of the Middle East Respiratory Syndrome, MERS, outbreak. It is of interest at this point to evaluate the current status of the epidemic, which is far from being contained or, for that matter, from being understood in terms of the epidemiology. Add to that the observation that severe disease has been seen primarily in older individuals with comorbidities, whereas, in contrast to severe acute respiratory syndrome, SARS, young, healthy individuals tend to have the asymptomatic to mild disease. The threat level to the world is perceived as much less with MERS as it was with SARS. Because SARS started and spread in China, which has formidable scientific expertise, and then spread to Western countries with their scientific resources may explain the differences in response to unknowledge about the MERS and SARS epidemics. Alternatively, perhaps the novelty of a coronavirus that was lethal for humans in the case of SARS attracted more attention of scientists and funding than the second-place MERS. We know that the novel coronavirus is responsible for both SARS and MERS, probably originated in bats and then spread to an intermediate mammalian host from which humans were infected. The discovery of civet cats as an infection source of SARS for humans occurred about 4 months after the international recognition that there was an outbreak of a new disease. In contrast, it was not until 10 months after the acceptance of MERS that camels were suspected as the possible intermediate host. Camels may not be to blame. In fact, although camels throughout the Middle East are serologically positive for a virus similar to or identical to the virus of MERS, there is no evidence that the camel is an important intermediate host. Only 9 cases thus far have reported a definite history of exposure to camels, or other farm animals, during the period preceding the onset of disease. Furthermore, the whole virus has not been isolated from camels. RNA fragments have been sequenced, and some have similar fragments as the viruses infecting individuals with known contact with these camels. However, until the whole virus is sequenced, we cannot be certain that it is the same virus that is infecting people. Furthermore, most of the cases did not have known contact with camels. It is safe to say that, at present, we still do not know the identity of the intermediate host. In fact, the actual mortality rate for MERS is most likely lower than the reported more than 40% because mild or even asymptomatic infections have been reported, and it is likely that others remain unrecognized. In the SARS outbreak, the cases were primarily seen in young, healthy individuals, whereas more than half of the MERS cases have been in individuals older than 50 years. More than 70% of severe disease and deaths in MERS occurred in people with comorbidities. SARS affected males and females equally, whereas more than 65% of MERS sporadic cases have been in men. The male predominance may possibly suggest either an occupational or cultural relationship. Both SARS and MERS have caused nosocomial outbreaks involving healthcare workers as well as other patients. It is probably related to suboptimal respiratory precautions and, possibly, procedures that resulted in aerosolization of respiratory secretions. Although MERS is clearly less infectious than SARS in terms of person-to-person spread, both in and outside of hospitals, the advent of superspreaders or a mutation in the MERS virus could change the dynamics of the outbreak. From experience thus far, it seems likely that the MERS outbreak will continue to limp along with sporadic cases occurring primarily in the Arabian Peninsula followed by nosocomial outbreaks when first introduced into a healthcare facility. This may change when the routes of transmission to the sporadic cases are clearly identified, or if there is a change in the virus leading to the superspreader phenomenon observed with SARS or a change in virulence of the virus. Without definitive identification of the non-human animal reservoir, there is unlikely to be a practical approach to stopping the epidemic. Even if camels are proven to be the animal reservoir, an approach to containment will be difficult without a vaccine. Unlike the civet cat in China, camels are important to the daily lives and economies of the countries in the Middle East, and the elimination of camels is unlikely to occur.